I am absolutely delighted to be with you. I should also share, I grew up on a farm in Frontier, North Dakota. There were 3 people per square mile. So I feel like I was born into rural health, and it's an absolute delight to have an opportunity to share with you today and also to learn from you. So I hope when we get to the question and answer, you can also share with me some of the things that you see that are changing in your environment and some of the things that may be helpful for you as you are transitioning now from volume to value. Just briefly, as was mentioned, I am part of NORC at the University of Chicago. I am the director of our Wealth Center for Rural Health Analysis that we are so proud to share. We are celebrating our 25th year. And all of our work is done in a nonpartisan way. And we also are nonprofit. And my office is actually located in Bethesda, Maryland. And I am about 15 minutes away, for those of you who've been to the Federal Office of Rural Health Policy, just 15 minutes away from their offices. So for today, I'm going to share about social determinants of health. I'm going to provide an overview of what social determinants of health encompasses. I'm also going to share some examples of how addressing these issues in value-based models can help improve the health and well-being of rural residents as well as the overall rural communities. And I'm going to conclude today with some resources and tools. But I think to start off our discussion, I'm going to share a story with you. I had the pleasure of evaluating a demonstration program that was implementing a care coordination model in rural Iowa. And when I was in rural Iowa, we had a chance to talk with the care coordinators, and they shared a story with me about one of the patients that they were helping to address a number of different issues under social determinants of health. This older adult male would frequent the ED with UTIs. He had urinary tract infections, and every time they would talk to this gentleman about what he needed to do in terms of making sure that he was drinking plenty of water and that he was attending to hygiene and taking care of his health, he would always respond that he understood what was needed and he would work to do better. Well, the community health worker went to visit him and found that he was actually living in the back of a machine shed in Iowa, and there was no running water. He was using an outdoor outhouse to go to the bathroom. And as you know, in Iowa, it gets pretty cold in the winter. So for him to use the bathroom at night, you know, it was dark and it was just a difficult trek for him to navigate to drink enough water in the evening if he needed to use the restroom. They also learned on their visit, or this community health worker, that he didn't have adequate food. So not only did he not have running water, but he wasn't getting food on a regular basis, good food on a regular basis. And he also had to rely on neighbors and friends for transportation. And so that community health worker was able to help him find affordable, safe housing, was able to get him connected to Meals on Wheels and get him enrolled in SNAP, and was also able to leverage the community organizations, particularly a couple of churches, in helping to furnish his apartment and to make sure that he was now also able to have access to a bathroom that had a shower. And so through this process, he was able to take better care of his health. And surprisingly, he was able to reduce his ED visits. So I share that story to provide a context of why social determinants matter. There are a couple of different definitions of social determinants of health, but the Healthy People 2030 that is funded through the Centers for Disease Control and Prevention, their definition includes the conditions in the environment where people are born, live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And the Robert Wood Johnson Foundation uses a somewhat different definition in their references to social determinants of health. And there specifically calls out important things like the quality of schools, access to good jobs with fair pay, and the safety of our neighborhoods. So there are a number of things that contribute to social determinants of health. And we can think of it in these 5 different categories. We can look at social determinants of health through the lens of healthcare access and quality, through the neighborhood and built environment, through our social and community context, through the economic stability, as well as education access and the quality of that education. The Kaiser Family Foundation has further defined what these different contributors are to social determinants of health. And for those of you that may be sharing information with your medical staff or with your boards, this may help to provide some context for you in presenting these concepts. Economic stability is really critical. I often say that I present information about health equals wealth. If we do not have people that are healthy, they are not going to be able to work. But likewise, if they don't have enough money, wealth equals health. So that is also an important component. So ensuring that people in your community have access to employment that provides them a livable wage that includes health insurance benefits so that they don't acquire a lot of debt and don't have a lot of medical bills with large deductibles and the like. That's a really important component of the social determinants. Likewise, ensuring that people have access to affordable and safe housing, as well as transportation and opportunities to be outside in nature with parks and playgrounds and feeling safe. I worked with one rural community in North Carolina, and their number one concern in their community was not the number of people with diabetes. Their number one concern was having street lights so that it was safe to walk in the evening. So that walkability piece is important. Likewise, ensuring that there's access to education. And what we often find is that people may not have the health literacy. They may not understand or have a background in health when we share information. For example, in discharge planning, it's really important to think about what people's backgrounds are and help people to understand the things that we take for granted when we work in health every day. It's also important to look at the early childhood education and access to health, childcare in our rural communities, as well as the whole continuum of education that really contributes to the opportunities that people have for employment and ultimately their ability to have livable wages. Food security is important. As we know, food is medicine, and access to healthy options is not always the case in some of our rural communities. So it's important to be able to assess those. Likewise, looking at the safety of our communities and how well people are integrated and what kind of issues are there for social engagement. I think through COVID, we all know the challenges of being isolated, and being able to look through that community lens is really important. And of course, lastly, our healthcare system is part of those social determinants of health. Do people have access to healthcare providers? Do they have insurance to help pay for that access? Do they have pharmacies? Do they have access to public health, to mental health, to oral health? Is the health service provided linguistically and culturally appropriate? What is the quality of that care? All those different components contribute to the health and well-being of our rural residents and the communities where they live. We also talk a lot right now about health equity, social determinants of health, and disparities. And I thought it might be also helpful for you to have these three different issues identified separately so that you can also help to share this information with your teams and with your stakeholders. Health equity, our goal is that every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. And a lot of times we look at issues of structural racism as well as economic opportunity. Again, the social determinants of health are very critical to achieving health equity. Having access to all the things we just discussed really help to advance health equity. And when we look at health disparities, that's really a way for us to measure or look at the metrics of how we are tracking health disparities and how we can measure then our progress toward achieving health equity. So again, this slide provides you with how these three are different and how they are linked together. Now I'm going to transition a little bit just to share some differences in rural that contribute to our social determinants of health. And as we talked about, wealth equals health. And if you look at our employment, what I think is really important to note here is that if you see how employment tracked until about 2009, when the recession hit our country, urban and rural were pretty consistently tracking together. Unfortunately, as our economy has recovered over time, we see that our rural, also noted here as non-metro, and by the way, that is unfortunately a way that a lot of demographers categorize rural. They have either metro or non-metro. So when you see these slides that indicate non-metro, that is our rural data. And as you can see with that orange line, our rural communities have never recovered. And we are still behind. And with COVID, we know those data will be even worse. So employment is an important issue to consider. Likewise, employment contributes to poverty. And this slide depicts poverty rates from 1959 through 2018. And as you can see, the rural is depicted as non-metro with the blue line. And we had considerably higher poverty rates among our rural residents in 1959 than urban. And although we are making strides and we have lower poverty in rural America than we did in 1959, rural is still tracking at a higher percentage of poverty than our urban counterparts. This also affects populations differently when we look at race and ethnicity. And as you can see in this slide, again, the non-metro or the rural is depicted in blue. The highest percentage of populations in rural communities that are living in poverty are those who are Black or African American, and those that are American Indian or Alaska and Native. The lowest is among white, non-Hispanic. But again, you can see across all race and ethnicity that rural have higher rates of poverty or higher percentages of poverty than their urban counterparts. We can also look at age groups. And as you can see, once again, the blue represents rural or non-metro. When we look at children, 1 out of every 4 children or child in this country in rural America is living in a family who is living in poverty. And again, that's considerably higher than children living in urban environments. And once you look across all age groups, again, you can see that rural residents are more likely to have higher percentages of poverty than urban, even across the ages. Education, we know, also drives some of these issues regarding poverty. And these data depict what has transpired over the last 20 years comparing rural and urban. And you can see that for both rural and urban, there has been increases in achievements in high school completion and also in college. However, our urban counterparts, about 35% of urban residents have attained a bachelor's degree or higher, in contrast to our rural at about 21% that have attained bachelor's degree or higher. And again, we often use the attainment of a bachelor's degree or completing graduate school as an indicator of a person's ability to be able to earn an income that has a livable wage and also includes things like health insurance and retirement. When we look across the social determinants of health, access to healthcare is also important. And this particular slide depicts the primary care health professional shortage areas that are designated through HRSA. And this is a slide, a map from RHI Hub. And the darker the green, the higher the HPSA, or the health professional shortage area score. And again, as you can see, we have a lot of dark areas in rural areas where we have less than optimal access to primary care. So with that, I'm going to shift gears a little bit, but I'm going to share a little bit about why now? Why are we talking about social determinants in a value-based healthcare world? And I think one of the exciting opportunities is that value-based care provides opportunities to address some of these social determinants of health while also improving value and quality of care. And one of the things that we have observed in some of the value-based care models is that we can have more flexibility in how services are provided. And this can translate into longer-term sustainability of better health. And it also can translate to improved population health within the community. And so I think I can share another story with you of an example of what I observed with another care coordination program that was part of a value-based care model. And again, they were leveraging data. That is one thing to consider when you are looking at transitioning to value-based care and reimbursement models, that you really need to look at your data systems. And this particular data, this particular situation was really driven by data. And they were looking at their ED utilization, and they found a person who was coming consistently to the ED with problems with her blood glucose. She was diabetic. And so they had a community health worker who was part of this care coordination program. And they asked to go visit her in her home. And she invited the community health worker in, and they sat down and talked about food. And again, she understood what she needed to do to be able to manage her diabetes. She was just having a really difficult time doing that and was ending up in the emergency department. And through their discussion, she was talking about her children who were school-aged. And she said, for example, she keeps 2 pitchers in her refrigerator, one with the children's Kool-Aid that has sugar in it, and one for ice water. And so the care coordinator asked to see her fridge. just to get a visual depiction. What does this look like for her? And when the woman opened the fridge, the only three things in the fridge were the two pitchers that she had just described and a small bowl of macaroni and cheese. There was no other food. And when she started talking to this mother, she shared that they had very limited food. And so she ended up making a lot of macaroni and cheese because it was inexpensive and it was a meal that could stretch. And so through this discussion, they were able to discuss different types of options for her. And so her children were able to get reduced or free meals at school and breakfast and lunch. And then she was able to get SNAP and WIC so that she was able to increase the availability of healthy foods and foods that were appropriate for her to better manage her diabetes. So again, through this accountable care organization program that this care coordination was funded by, it helped them not only identify where high utilization people were in their system, but it also provided a targeted way to be able to meet the person where they were, assess what their needs were, and help to put a strategy together to not only reduce the amount of healthcare that she was seeking, but to improve her overall quality of life. And so that is one way that value-based care, delivery, and reimbursement models and programs can help to shift some of the resources in your organizations to be able to address some of these challenges that keep people from being able to experience optimal health. Now I'm going to shift to some of the tools and resources that may help you as you are navigating this shift to value-based care and addressing social determinants of health. We had the good fortune of developing this guide that was funded by the Federal Office of Rural Health Policy, a guide for rural healthcare collaboration and coordination. And this guide provides some really important information about how you can think about incorporating community partners. Because really, when we're looking at addressing social determinants of health, we're really looking at cross-sector engagement. We're looking at not only having this all on the shoulders of healthcare providers, but also engaging with public health, with social services, with your community-based organizations, really leveraging those assets in your rural communities to be able to come together collectively and address the needs that you see and are able now to better track and address through some of the value-based payment opportunities. And again, data is going to be really important for you as you navigate these new waters. This guide also includes 2 case studies. One case study is by the Healthcare Collaborative of Rural Missouri, and it features an FQHC. And by the way, that FQHC started as a network planning grant under the Federal Office of Rural Health Policy. So they were able to incrementally grow and address locally identified problems. And so this FQHC and now the overall collaborative has over 60 different members addressing the health needs of the population that they serve. The second case study comes to us from Beulah and Hazen, North Dakota, where we have Sakakawea Medical Center, a critical access hospital, and Coal Country Community Health Center, an FQHC, working not only together with shared mission and vision, but also a shared CEO that is leading the organizations to address those unique issues that collectively they can improve when they are able to use their resources. This guide provides some some information to really address some of the things that you all may face. We know that there are challenges in our rural communities. We have sometimes limited economies of scale. And as healthcare providers, many of you are heavily dependent upon public payers, and some have low patient volumes. So that can contribute to some real challenges in trying to stretch your dollars and also stretch your staff, because we know that a lot of your staff are wearing multiple hats. So to ask them to do one more thing can be really challenging. But if you can be able to shift your resources through a value-based payment model, that may help you to address some of these issues. Sometimes too, there's just a lack of collaboration that can, within organizations, that can put an organization at risk, because again, we are all operating on shoestrings in many of our organizations, but it's really important to think about how, when you come together, you can leverage those resources. One of the things that you also need to consider when you start shifting from volume to value is that it's going to cost some money. You need to think about investments that you want to make in data and being able to translate that data into usable information for your staff and your team. You may want to also invest in some additional staff training. It's a new mindset to think about how are we going to address some of these social determinants of health when before we were not in that mindset of trying to look upstream at what might be contributing to the way people are using services. There's also a lot of interest in moving to more patient-centered approaches to address social determinants of health, to ask people through motivational interviewing training, for example, to really get at what are their goals and how can you leverage those goals to be able to help them experience the best health that they can have, again, meet them where they are. There are 4 different elements in this particular guide that may be helpful as you're thinking about collaboration and care coordination as part of your value-based efforts, and particularly as you're looking at addressing social determinants of health. Having a good pulse on the environment, that analysis piece is really important, not only understanding what's going on in your community, but also understanding what your partners can bring to the table. And are there any things on a national level, such as maybe being able to write grants to the Federal Office of Rural Health Policy or work with foundations to be able to get some seed money to help convene and bring partners together to address social determinants of health. Engaging with partners also takes time, and also it's really important, we learn from our case studies, that everybody comes to the table with a community mind approach. You really need to be community minded to think about what are the best things that can advance the health and well-being of your residents and your community. And in doing so, to develop a collective strategy where everybody comes together. And one of the things that we learned from the case studies as well was it was really helpful to bring in a trained facilitator to help in getting those discussions together, especially when you start bringing multiple different organizations together. It's really helpful to improve and to track how you are moving forward, and to be able to monitor, are you making a difference? That is always a question that we ask. We all have, again, limited resources and limited time. So how can we best use our time and resources to address social determinants of health and to improve health outcomes in our communities? And lastly, to make sure that we all review our requirements and seek technical assistance. Oftentimes, organizations have programmatic and regulatory compliance issues. Our critical access hospitals, our community health centers, our rural health clinics. We all have different requirements. And those are first and foremost because we need to keep our doors open. And again, when we have questions, seeking technical assistance is always helpful. There are people out there that are doing this, and you have a lot of resources with the National Rural Health Resource Center. And I'm going to share a couple of more that we have online that might be helpful for you as well. The first resource with regard to screening tools is actually an assessment tool that is maintained by the National Association of Community Health Centers. It's called PREPARE. And this is a protocol that really helps to capture information in a form. And I'll show you a form in just a moment. But it really helps to assess some of those really important components of social determinants of health. Not only being able to get good information on the background of a patient, including things like language preferences and veteran status and those types of things, but it also helps to provide information so that a person has better understanding of what their education and employment background is, information about their health status and insurance status rather. Do they have coverage? Are they not seeking care because of high deductibles or high out-of-pocket costs that they have to incur? And also to understand, is transportation a potential barrier for them to be able to get care? Those types of things are important. There's also questions about family and home. Again, that housing piece. There is some literature out there about where your highest return on investment is. And what a lot of social determinant data are showing is that when you can identify issues related to housing and nutrition, that's an area where you really see reductions in potentially avoidable utilization of healthcare services. So that's important data to capture. That social piece, do they have support, engagement, care providers? And then, of course, some of those other pieces of information that often aren't collected. Understanding about safety. Is there an issue about domestic violence? Collecting all that information on this kind of a form. There are some electronic health records that have developed interfaces so that this tool, PREPARE, can provide information and share information back and forth. And what's really cool about what this tool can do is that during COVID now, the organizations that have implemented PREPARE have also been able to use the tool in assessing how to respond. Looking at response from an individual level, looking at where are the patients that may need special outreach, looking at from a population level, are there patients that have high risks, for example, that may need to have some additional support and additional outreach, making sure that they're having appropriate check-ins. And then lastly, looking at some of those system or policy. Are there people that are disproportionately impacted? And when you have that data and can summarize it in a very efficient manner, it provides you some information, especially in this case, in a response to something that we needed to get information on in a very short order. And in fact, the Healthcare Collaborative in rural Missouri shared with me that one of their #1 issues that they responded to early in the pandemic was food security. And they were able to work closely with the community organizations to ensure that there was increased access to food banks, and they collected information on food access for every single patient that they served to ensure that people had appropriate access. So in summary, when you're thinking about demonstrating the value of social determinants of health, there is often a return on investment piece that you may want to think about. Transportation, in addition to housing and nutrition, Addressing transportation has also been shown to reduce, for example, addressing upstream issues. I worked with a grandmother in a rural community who was getting guardianship for her grandchildren due to the untimely death of their parents. And the provider said that she could not even talk about her diabetes, care for her diabetes, because she had such concern about having adequate supports for her grandchildren, including a bed. And that community health worker in that particular rural health clinic was able to get her grandson a bed. And then when she came in for her next appointment, they could talk about her diabetic care. But until she was able to address taking care of her immediate need, which was her grandson, she could not address her own healthcare needs. It's very important to promote community participation, that assessment, looking at how you're going to design your program, identifying links and doing outreach, as well as providing some kind of evaluation to see what works, what doesn't, looking at special populations, as well as exploring some additional training, as I mentioned, motivational training, and also looking at leveraging reimbursement opportunities. And what we see a lot of communities and organizations doing is using that chronic care management and transitional care management codes that we have through Medicare to also help address some of these social determinants of health. This is a really slick model. I've used this model for over 20 years. It's called the Avi Model. And basically, you just follow it. You start, you analyze where you are, you design how you're going to address a program, what you're going to do, and then you develop the steps in the program that you just designed. You implement the program, and then you evaluate. So it's a circular model. And what's really great is ADDIE encompasses the first words of each step. And so this has been a really useful tool in many communities to be able to see, especially when you're bringing multiple organizations together, a process, because again, we don't have enough resources. We need to make sure that we are allocating our resources in a very efficient manner to be able to achieve the goals that we set forth. And now I'm going to shift to our toolkits. Again, these are funded by the Federal Office of Rural Health Policy. These toolkits are to share more of the evidence-based practice and promising practices in rural communities. And so we do some in-depth studying on what's happening in some of our rural communities. For example, right now we're working on a health equity toolkit, and that toolkit will be available in late 2021. And these toolkits are developed in modular fashion. And these modules are developed so that you can go at any place where you are in addressing a topic, such as our social determinants of health toolkit. And these different modules provide information, such as our program models, where you can find different programs that have been implemented and have demonstrated success in improving economic stability, improving educational opportunities, social context, and the like. We also have a program clearinghouse, which has specific examples of rural programs, and it has the contact information for the program implementers. So it gives you an opportunity to be able to connect directly, because we know in rural, we like to talk to the people who are actually the boots on the ground implementing these programs. And if we have questions, it's often helpful to learn directly from them how they might have approached an issue that our group is approaching. We also have a number of other toolkits in addition to our social determinants of health for rural people that may be helpful as you are looking at addressing social determinants in your value-based care environment. Again, these are all available on the RHI Hub web. Our colleagues are also available there. If you have any questions, you can call their 1-800 number and get a response either through telephone or also by email, usually within 24 hours. And again, remember, this is paid for by the Federal Office of Rural Health Policy. It's for you. It's free. With that, I'd open it up to some questions.
Alana, we do have questions. We do have questions. I'm so glad that we have some time for this. So while we're taking some of these questions, Angie is going to put a couple more polling questions up. She'll leave them each up for a couple minutes or so. And if you guys will answer those as we are going through questions. But let's see. So the first question was from Katina Cummings, and she says, Dr. Knudsen, do value-based care models you have researched and know about incentivize the hiring of community health workers as part of the patient care team? Great question.
Yeah, community health workers have been demonstrated to be really successful, in part because, again, you know, the important part is meeting people where they are. And, you know, I will tell you, one of the lessons learned that we heard from multiple organizations with community health workers, you really need to take the time to hire the right person that has the right way of connecting. Because, you know, nobody wants to be told what to do. I don't want to be told what to do. And so, you know, hiring somebody who is able to really talk to that person and understand where that person is coming from, as well as to ask them questions. So that rapport piece can't be emphasized enough to be effective as a community health worker.
All right, and then a question from Warren L. Dukes. It was when you were talking about, he was asking about where the state of Iowa fits on the previous slide. And I'm trying to think what slide it was. It was regarding, let's see. Warren, I don't know if you can unmute for a moment and ask Alana. And
yes, I'll be happy to share that with you. It was in reference to the slide that she shows with the diagrams and demographics regarding rural health providers.
Oh, certainly. With the primary care, with the HIPSAs?
That is correct.
Yep. Now, remember, when we're looking at primary care, these are primary care physicians only. That is how the health professional shortage areas are determined. So there are no other types of providers included in that. They are primary care physicians. Is that helpful? Community health workers, for example, would not be included in that, nor would nurse practitioners or physician assistants.
That did clarify.
Yep. Is that okay? Great. And please know you will also have my email at the end too. And so if you also think of something else or we're not able to cover it, please reach out to me. I'd be more than happy to either talk to you or send you a response in email.
Okay, and another question, Alana, from Sharon. She says, are you aware of any payers that are currently including social risk screening, Z codes, and increased risk adjustment incentives for the patients that are requiring more touches to manage their chronic disease?
No, that's interesting. There are some discussions going on. There's some demonstrations that are in play, and I would be happy to follow up with that one and provide you some information about, I just can't come at the top of my head about the specific names of these demonstrations where they are looking to see if there is evidence on the cost side to be able to do this tracking.
Thanks, Alana. And then Warren L. Dukes, he asked, would you please show the toolkit slides again? Can you?
Oh, absolutely.
You able to go back a little bit so folks can look at that? And I have to say,
the poll has to come down, or I can't do that.
Oh, you can just exit out.
Oh, sorry.
You don't have to keep it
good,
up.
good. Okay, I'm sorry.
No, that's all right.
Are these the toolkit, or do you want to see the other ones?
Those are the ones.
Yep. Mm-hmm. And we're really excited because, you know, the health equity toolkit is going to be very comprehensive. For those of you who may be applying for any types of grants through the Federal Office of Rural Health Policy, health equity is part and parcel to every single grant proposal going forward. And so we are hopeful that that toolkit is also going to provide some really helpful ideas about how to address health equity and some of the programs that are already demonstrating success.
Okay, Alana, another question. Are you aware of, when will community health workers start being paid directly by payers? This is a huge issue in employing community health workers.
You know, you raised such an important question. It is. And, you know, we know that Medicaid allows, you know, if you have a waiver, state waiver, you can get reimbursed. But in terms of direct reimbursement for community health workers, they are still being reimbursed through the organization that employs them. So, you know, that's where they get paid. I think you raise a great question. And I think, I don't know where payers are. I have not heard of any, I've been in some discussions with commercial payers. I have not heard any commercial payers talking about direct reimbursement to community health workers.
Okay, another question. Are you aware of any communities who have successfully addressed the issue of transportation?
If you go to our transportation toolkit, the last one on this slide, there are some communities that have done so. And one of the things that I really love about our toolkits is that there is an implementation module. And we learned some really interesting things in the transportation realm. And that is some rural communities have established like a volunteer bank of drivers. However, in doing so, they also learned that it's really important to check on the insurance piece for that. Because sometimes it puts the volunteer driver, the liability is on them. And so unless they're really clear about what they're taking on, they could be somewhat surprised. So one of the things that I think the toolkit really helps you to do is to think about what might be some issues that you might want to just make sure are on the table as you are designing a program. We've seen some incredibly successful volunteer transportation programs, for example. We've also seen in some communities, some places where they're able to leverage different transportation providers through the VA and through Indian Health Services. And also some of the, as you know, through Medicaid, there are transportation reimbursement to get people to appointments. So Oregon has been particularly innovative in looking at how to leverage those services so that more people could benefit. Because if you're going to be transporting a veteran from point A to point B and other people need to go, why not add those other people? So it's fun to see that innovative thinking come through.
Sure is, and people getting out of their own silos with that to provide the care. That's great. Another question, Carol Masden says, Alana, the Maryland Rural Health Association is so proud to have you on our board. I've seen social determinants of health codes which can possibly be used by providers, hospitals, etc. Have you worked with any providers who have used the codes, and did their data help better inform their practice? And what guidance might you offer in efforts to use social determinants of health coding? Thanks.
Wow, what a great question. And thank you. I'm honored to serve on the Maryland Rural Health Association board. One of the things that we have also been looking at, and stay tuned, we're going to do a dashboard webinar a little bit later talking about the use of dashboards by some of the former Federal Office of Rural Health Policy awardees. But there are ways, data is so important. And you know, one of our challenges is we have mountains of data untouched by human thought in all of our organizations. And that was a quote from the former behavioral risk factor surveillance system director. It's not my brilliant quote, but essentially what we really need are data to be able to identify. And if you're getting into any kind of value-based payment and delivery systems, you are going to need to make sure you have data, because an important consideration is you need to find out who are those high utilizers, who is using the ED, why are they using the ED, what interventions, what kind of care coordination, what kind of community health worker engagement can there be to be able to understand what the issues are and how you can mitigate those. So data is part and parcel. And if I have heard anything from providers across the country in value-based payment models, the most important issue that they face is making sure that they have adequate data to inform decisions. And that's why these tools like Prepare and those types of tools are really helpful, because they also provide another piece to the puzzle so that you have a little bit more information and you can link some of this patient information to some of that background information that may not be captured in a 15-minute appointment with a primary care provider, especially when somebody has multiple chronic conditions. And frankly, you know what? We have a lot of very proud people. And that story that I shared with you about the gentleman in Iowa, he had had many histories taken. Nobody knew that he was living in the back of a shed. So, you know, we don't often share some of those kinds of details when we talk to our primary care provider.
All right, and Alana, we are out of time and we still have more questions, but I was just thinking we might have to have you back in this next program year to do part 2 of this and just continue this really helpful information. So thank you. Again, this has been just an amazing presentation and so much interest. So I want to thank everybody for being here. Thank you, Alana, for sharing this great information and taking all of those questions. If anybody has any questions about the RIPT project or about the upcoming application cycle, please feel free to reach out to Angie or to me. And we hope that everybody has a wonderful rest of your day. Thank you. Bye-bye.